we have a special guest, and it's a Zoom seminar today. Dr. Paula Strassle. She's an assistant professor of epidemiology at the University of Maryland. She received her PhD from University of North Carolina, Chapel Hill, and joined University of Maryland in 2024. Before that, she served as a staff scientist in the Division of Intramural Research in NIMHD at NIH. For those of you who don't know what that is, that's the National Institute on Minority Health and Health Disparity. She's the director of the Decode Lab in Maryland, University of Maryland, which stands for Disaggregating the Causes of Disparities in Healthcare. That itself defines, the research focus, which is on addressing differences and disparities across clinical care continuum, especially in ethnic minority population and rural communities. She will be presenting on that topic today. Dr. Strassle, welcome to the EPI seminar, and over to you.
Yeah, thanks so much for having me. Today I'm going to be talking a little bit about what I spend most of my time thinking about, which is trying to disaggregate health differences and health disparities in clinical care. This is a quick agenda, but before I get into that, I've been asked to speak about a little bit about how did I end up here as an assistant professor at the University of Maryland. So, when you put it all out on a timeline like this, it seems really streamlined. I got my undergrad degree. I then worked in a department of epidemiology at a school of medicine, actually at the University of Maryland. I then went on to get my master's at Emory and work at the CDC while I was there. Then went immediately into my PhD at UNC, where I worked as a graduate research assistant in the Department of Surgery. And there I ended up accidentally building them a research core, which I stayed on to run for a little over a year after I graduated, and then went on to NIH and Maryland. But I think what this timeline doesn't really share, and something that I felt a lot as a graduate student, is that I had no idea what my research interest was or what my focus should be. And so I think this picture gives a little bit of a oversimplified version of what I was thinking about. So when we actually look at my research, it feels more like a squiggly line. So don't feel like, if you don't know exactly what you want to do in undergrad or in graduate school immediately, that you can't have a good trajectory. So I started out studying hospital-acquired infections. How did I end up there? Well, I graduated in 2010 and needed a job. And this was the first place to hire me when I was looking for clinical research positions. When I went to the CDC, I started studying disparities in healthcare, specifically cleft care for kids. Again, how did I get there? I needed a job, and they had some interesting work in survey methodology that I thought would be interesting, which is why I chose them. I then went on to work more in HAIs and burn patients, which is how I got involved in the Department of Surgery. The Burn Center was part of the Department of Surgery at UNC. And then I ended up studying risks and outcomes, discovering my interest in surgical disparities, then realizing that a lot of these disparities maybe could be addressed if we addressed upstream disparities. So if you prevent the disease altogether, or you can better manage the disease and reduce disparities there, maybe we can, mitigate surgical disparities. And so in order to kind of develop my health disparities framework and training, I went to the NIH for several years, got into studying COVID because I started there in 2020 and everyone was studying COVID at the time. But that kind of shifted me into preventative care. And then now I'm focusing in cancer care continuum, so kind of combining everything together, both from preventing cancer to screening cancer, treating cancer, which includes surgery and outcomes. So I kind of picked up pieces along the way. But looking at it on paper, it's very a little crazy, especially if you look at my resume, some of my publications. It's how did I end up on that paper? But what I got very good at is putting a good narrative on it and focusing more on the skills I was building and the through lines through all of my work. And happy to talk more specifics about this if there are questions about my research or about how I ended up here. But to jump into my research, um, right now, I think a lot about health differences, disparities, how we measure them, and why it matters. So, if we look at least at the NIMHD definition of health disparities, this is how it's measured. So, it's differences in health outcomes among disadvantaged populations, and they define those disadvantaged populations. But the really important thing is that as you can see, it's higher incidence, greater burden, poorer outcomes. And what do these measures all require? Well, the answer is a comparison group, right? For someone to have a higher incidence, you need to say compared to whom. And so health disparities are really identified using a reference point, and it's something that I don't think we think enough about. We commonly compare, especially when thinking about racial and ethnic disparities, or comparing them to non-Hispanic white, which I think is problematic. First, it can create this incorrect assumption that whatever the outcome rate or incidence is in white individuals is what we consider the gold standard, which is not always true. One, we could have more outcomes than we would want in that population, but also there are a lot of instances where non-Hispanic white don't have the best outcome. And so, what does this comparison mean when they don't have the best outcome when we're comparing to them? Another way to get at these reference points is we can also set one, right? So, for example, Healthy People 2030 sets all these benchmarks for, goals we want to obtain about screening rates or incidence rates for these diseases, but it can be really difficult to determine and identify what an appropriate benchmark or reference point should be if not part of a larger health effort like this. And as we'll talk about later, the motivating example is amputation rates in patients with vascular disease. Ideally, we want it to be zero, but realistically, we know that's not possible given the disease. And so it's unclear what that bench point should be set to. Something that I also think a lot about is that disparities, as we know, occur across age and disease progression. And depending on when we focus our research question, it can be too late to address upstream disparities. Again, if we're thinking about surgery, I can't prevent disparities in the prevalence of the disease because I'm farther down where we're interacting with these patients is farther along the kind of health continuum. But these disparities still get baked into the results. And so, what do I mean by that? Again, using amputation as a disparity, when we look at amputation rates when we try to identify disparities, we typically look at it as the number of amputations among patients who have a vascular disease, in this case specifically peripheral arterial disease. But what this doesn't take into, so when we look at it face on, it looks like the one group has worse outcomes than the other. 25% is higher than 15. But when we restrict to patients with severe PAD or severe disease, in this example, where intervention would be required, we now see that there is no disparity. And in fact, the disparity is occurring upstream, that this population on my right, I don't know if you're left or right, but the one with the larger denominator, this one here, the disparity is occurring upstream, right? There's more patients with severe disease, which a surgeon can't solve, but, could be addressed further. But at the time of surgery, there's no disparity in amputation when we account for these clinical differences. And so I think this is something that I've been thinking about and I try to take into account in my research. And again, not all health differences, so even if we do see a higher rate in a population, like that prior example, not all health differences are considered disparities. So when we look at, this definition in Healthy People 2030, for example, the difference has to be closely linked with social, economic, or environmental disadvantage and has to occur in a group that systematically experiences greater obstacles to health. Just because the prevalence of many chronic conditions are higher in older adults, we would never say that elderly experience disparities. Another good example is, professional athletes have a much higher injury rate than the general population, but that's not a disparity. That's due to, job differences, and is more of a choice. So One thing that individuals in health disparities, when we think about methodology, have been trying to do is differentiate what we consider allowable versus unallowable differences. And so the total difference is a mix of this, and we need to be able to remove the allowable differences in order to accurately assess whether health disparities exist. And so a nice visualization is this is if we see in this example, we have an advantage and a disadvantaged group, and then we have some adverse outcomes, so a lower rate is better. The total difference here is a mix of allowable and unallowable factors, and when we look at them specifically, this can consist of differences in biological or clinical factors. Patient preferences may play a role, healthcare systems, the legal and regulatory climate, bias and stereotyping, and then physical and built environment or, those kind of structural barriers. And so these top ones contribute to disparities and would be considered unallowable, where these bottom two, the biological and clinical factors and patient preferences, would be considered allowable. So again, patient preference being they become a professional athlete versus they don't, or biological older adult versus younger adult. When we see those differences, we don't necessarily say that they're due to disparity. They're due to these allowable reasons. However, if the disparity or the difference, at least in part, is due to any of these unallowable factors, we would say that a disparity does exist. And so there is a need for new approaches to assess the presence of health disparities that account for these kind of biological and clinical differences, which may or may not be caused by upstream disparities themselves. But I try to approach my research at since I conduct a lot of clinical work at the time of like clinical intervention. So when that patient would first present themselves to me, could I prevent a disease they developed 5 years ago? No. So that's kind of the approach I take. So even though some of these biological and clinical differences may be caused by upstream disparities, at the time they are, I'm not a clinician, but at the time they're in my hypothetical, patient, my office, as a clinician, it's more of a baked in factor at that point. So I'm going to talk specifically today about this approach that I developed. This came out late last year in epidemiology, and you can see my co-authors on the side, and it's made up of a mix of epidemiologists, vascular surgeons, and a medical resident, where we looked at disaggregating these differences using machine learning and observed to expected ratios. And I'll walk through the process and the specific results from this analysis. And just because I was employed at the NIH, at least partially when I started this work, I was employed by the NIH, and so my funding statement is here. Nothing I say or this paper doesn't reflect the views, but as mentioned, I'm not there anymore. So let's talk a little bit about what MMLA or major lower limb amputation in patients with peripheral arterial disease looks like. So for those who are unfamiliar, PAD is a chronic condition where plaque buildup leads to reduced blood flow to the legs or other extremities. It's most common in the legs, but you can get it in the arms as well. It causes leg pain, numbness, weakness, and in severe cases can lead to infection due to reduced blood flow and then eventually limb loss. About 12 million individuals in the US are diagnosed with PAD, so it's a pretty common disease. And when we look at PAD and advanced, because everyone wants to come up with new names, advanced stage or severe PAD is called chronic limb threatening ischemia or CLTI. So this is when PAD progresses to a point where there's pain in the feet or lower legs even when not moving. It's also called ischemic rest pain. When they develop non-healing wounds or ulcers or develop gangrene, a lot of times this happens in the toes. And overall, about 10% of adults with PAD go on to develop CLTI. So about 10% of patients with PAD go on to develop this kind of serious, progression of the disease. And essentially, when a patient develops CLTI, surgeons and clinicians have to restore blood flow to the lower leg, or they will end up losing the limb. And so CLTI can be treated through medical optimization, revascularization, and wound care to try to prevent major complications. One of the most major ones being major lower limb amputation. So if they can't, revascularize or restore blood flow, then they have to amputate in order to reduce the risk of that infection or issues from spreading further up the limb and then requiring a higher amputation, for example. However, in MMLA or in CLTI care, even when treated by multidisciplinary teams and when aggressive limb preserving interventions are taking place, there's significant variability in what interventions are offered and when. There's no strict guidelines as to what has to be offered in what order, or if all of those steps need to be offered to the same patient. And when amputation is required is also relatively subjective and will vary across teams. So there's a lot of decision making that has to be done by the teams, which could potentially allow for things like implicit bias to kind of creep in because there's so much space for individual decision making to occur. So, some surgeons, however, point to differences in biological or clinical factors for why MLMLA rates are higher among marginalized populations. They're about twice as high, the black-white amputation rate. And so basically what they're saying is that none of these factors exist. It's only biological and clinical factors, meaning that their Black and African American patients are presenting with more severe disease, they are presenting later, and that's why their amputation rates are higher. And so this means that their differences are allowable, right, if they're truly due to these biological or clinical factors. So that would mean there'd be no disparity. And why this matters is if there's no disparity, then there's no need to try to change how things are being done, right? There's no need to try to fix things or develop more stringent protocols to try to make care more equitable. There's really no problems. So, me and my colleagues were interested in trying to answer the question, do biological or clinical factors fully explain the differences that we see across race and ethnicity and rurality? And if not, if disparities do exist, does implicit bias play a role? Now, between these questions and some of the things I pointed out earlier about how we measure health disparities, we decided, or I guess I decided, that I needed to develop an analytic approach that one wouldn't require us to compare the populations to each other. So we would remove the non-Hispanic white reference group. We can compare Black patients to Black patients, etc. I wanted to separate out these allowable and unallowable differences. I wanted to be able to incorporate potentially hundreds of parameters and their interactions between each other. I wanted the analysis to be able to be intersectional. We wanted to look across rurality and race at the same time. So I wanted to build an approach that would allow for that easily. And then I'm always one who's interested in trying to make sure that my results are easy to interpret and ideally have nice visualization, especially in order to get these results out to clinical and non-research audiences. And then as an additional step, structural and implicit bias is almost always unmeasured. And so I wanted a way to try to, at least in a backhanded manner, kind of assess whether there is the potential for this to play a role in MMLA disparities if they do exist. So I actually got my inspiration for this analytical approach from older research. So this paper came out in 2007, and they used observed to expected ratios to try to evaluate variation in the VA to see whether there were hospitals performing more or fewer major and minor amputations compared to other hospitals. And so I got inspiration from here. This was one of the papers my fellow at the time pulled during the lit search when we were preparing to put together this project on amputation. And so I got inspired by this and I developed an approach where we calculate observed to expected ratios within each patient population as opposed to within each hospital setting. And we use that to identify health differences and disparities and then estimate the expected number of events using multiple AI models or ML models to tease out these allowable and unallowable differences. So let's walk through what this would look like. So To calculate the observed to expected ratios themselves, what I did is you predict the probability of the outcome. So traditional kind of predictive analysis using AI or machine learning. The paper that I published uses Lasso, but we're now pushing this to more semi-structured and unstructured approaches. And you do this in the total patient population. You then split the data set by race and ethnicity or by other sociodemographics or by a combination of them. And then you sum the actual number of the outcomes. So you look in the, in this example, black patients and white patients, count how many amputations they had. You then sum the predicted probabilities across those patients to get the expected number. The logic behind that is if you have 5 patients with a 20% chance of having the outcome, you would expect there to be one outcome in that population of 5. And so by summing the predicted probabilities, we can get at the expected number that we would hope to see. And then you use those two to calculate an observed to expected ratio, very similar to the chi-square that we're hopefully very familiar with. And then just as a note, a greater than 1 observed to expected ratio would indicate more events than expected. Whether that's a difference or disparity depends on what you put in the model, and we'll talk about that shortly. And then you bootstrap to get confidence intervals. So you do this entire process 1,000 times is what I did. You could probably do it fewer to get confidence intervals around those observed to expected ratios. And then, happy to talk more about the machine learning approach, but just know that we did do some validation, cross-validation by splitting the data set into training and testing. And then we also do some statistics to check that the fit is of that predictive model is similar across race, ethnicity, and rurality in this analysis. But you would want to check it across whatever populations you're looking at in your analysis. So to estimate, so if that's the general approach, then how do we use these predictive models or multiple predictive models to determine what the total difference is, the difference after accounting for allowable, and the difference after accounting for allowable and unallowable? What do they tell us? So we would run 3 models. So the first model would be intercept only, or in the case of my multi-state analysis, which we'll talk about, I actually include state in this intercept only model. And so when you compare the odds ratio, so here the odds ratio is 2 for the intercept only model. And so when you compare that to the expected value of 1, which would be no difference than what was expected, that tells us the total difference between what's observed and what's expected. When you add in the details from the model, which only includes allowable factors, so this would be a model with clinical factors. If you have information on patient preferences, you would include that as well. And then that kind of splits the total difference into what is allowable and then what is unallowable, that unallowable difference being the disparity. And then that third model, which adjusts for allowable and unallowable, so has the clinical factors, and then you add in all social determinants of health, and other, healthcare system factors in as well. That will split the unallowable difference into what's explained by the variables you include in the model and the variables that in the proportion that remains unexplained. The idea being that the allowable difference is the proportion of the observed difference due to biological and clinical factors and patient preferences. The explained factor due to things that we can measure like healthcare systems, legal and regulatory environment, the physical and built environment, and then the unexplained would ideally be bias, what's left that we can't measure, which is, at least in these databases, biases and stereotyping. So in this example, we could see that 50% of the total difference is due to allowable factors, and then half of the unallowable factors unexplained, so 25% would be due to biases or other factors that we weren't able to measure, and then 25% due to ones that we could. And that's the approach. So when we apply it to a real data set and analysis, so when looking at this amputation project specifically, I use the Healthcare Cost and Utilization Project State Inpatient Databases, or SIDS, from 2016 to 2019 For those unfamiliar, the HCUP databases, it's an all-payer, at least these ones are statewide databases of inpatient discharge records. So hospitals are required to report all of their discharges to the state, which then go on to give it to AHRQ, who then compile these data sets. And then we chose Florida, Georgia, Maryland, Mississippi, and New York for our analysis because these states have a unique patient ID, which means that you can follow patients over time. Not all, it's an option. Not all states do that. So while there's a unique hospitalization ID, not every state reports a unique patient ID, which means that you can't track people over time. So this one we could, which means that we could look back at a patient's prior healthcare utilization, at least inpatient, to capture covariates. And then these states also provide patient zip code, their billing zip code, which means that we could link to zip code and county level healthcare characteristics and neighborhood characteristics like median income, the proportion who graduated high school, those kind of structural factors. We included all PAD and CLTI hospitalizations of patients at least 40 years old from 2017 to 2019 in the analysis. We did a 1-year look back in order to capture comorbidities and other characteristics, which is why the data set runs from 2016 through 2019. And then we excluded patients who were not a resident of the state they were admitted in. If you were treated in Florida, but you really live in South Carolina, then, we would expect most of your healthcare utilization to be in South Carolina. So we thought there'd be some significant missing data there. We also excluded patients missing that key linkage variable, patient or hospital ID, and then those who are admitted for lower limb trauma or admitted through a trauma center, which would indicate they might have, if they have lower limb trauma, things like car accidents or other those things, which also are a risk of amputation. We wanted to remove patients who also had any of those additional indications, either at the time of admission that we were looking at or within the year prior of the admission we were looking at. So we ended up with a little over 2 million hospitalizations to start with. And then after we applied our exclusion criteria, we ended up with 1.5 million observations and a little under 1 million unique patients. So we did allow individuals to be admitted or have multiple admissions meet the inclusion criteria. When we looked at the covariates that we included in our model, we broke them down into the clinical biological. In this case, we didn't think their patient preferences would be applicable. We decided that all patients would prefer to not lose their limb if given the option. So we assumed everyone would have the same preference of having their limb restored and not cutting it off. We captured several healthcare system variables. So there is a unique hospital ID as well. It doesn't tell us what the hospital is, so we can't go looking around to try to find, this is Maryland, the University of Maryland medical system and pull factors in there. But because we have this unique ID, we can count how many PAD hospitalizations they had in the year prior to that hospitalization, how many amputations they performed, both major and minor, how many revascularization procedures they perform. And then we also had information on the expected payer for the patient. And then we had the kind of social determinants of health bucket, which kind of fall into the legal, regulatory, and physical built environment. There are no sex differences in PAD specifically, so we decided that if any differences were seen across sex, they were likely due to social determinants of health or differential, access to care, as opposed to kind of clinical or biological reasons. Other analyses that we're currently conducting, sex sometimes ends up in that clinical biological bucket when we do know that there are clinical or biological mechanisms where sex would be explained through that. And then we linked almost 24 neighborhood factors, how dense the neighborhood is, so how many people live there, the demographic factors of it, income, employment, poverty, resources, healthcare access. Overall, there was over 70 variables. So in the final allowable and unallowable factors model, and we included additionally all two-way interactions between all of those factors. And so when we look at the breakdown of some of the demographics, we can see how many hospitalizations and unique patients we see, the fact that some, state size and age distribution contribute to why certain states have more hospitalizations and patients than others. But we can largely see that there isn't a ton of differences across demographics, some race ethnicity ones, but again, that's more due to the state makeup. And then we do see a little difference in amputation rates. Mississippi has a higher rate than other states, but only slightly so. However, when we run our models, so if we plot our factors, so again, we stratified by rurality and by race ethnicity. And so this gray dot here for each of them indicates what the intercept or state, adjusted for state only model looks like. So for example, rural Native Americans had 4.5 times more amputations than what would be expected in a model where we don't include anything. So it's basically compared to the overall amputation rate in the data analysis population. But we can see that a lot of populations have more than expected amputations. When we adjust for allowable, so adjust for allowable differences, adjust for clinical factors, almost every population, we see a shift towards the null, towards one, which is what's expected. So we can see big shifts. However, the fact that these red dots are not all on that line, that black line at one, tells us that disparities do exist. And then when we further adjust for allowable and unallowable factors, again, we shift even closer to the null for a lot of these minority populations. However, there still is a gap, indicating that there are unexplained causes to the disparities in our model. And we can look at this in table form as well. So we can see the three observed to expected ratios in the first three columns. So we can see again, here's the intercept only model. So we can see that most populations experienced, these are the populations that experienced more than expected amputations. And when we adjusted for allowable differences, we can see about half of them. The Native American population was quite small in our analysis, so some of the results need to be interpreted with caution, but roughly about half of all observed differences are due to allowable factors when we look at populations that have more than expected amputations. And then when we look at explained versus unexplained, we can see that there is still a pretty meaningful proportion of unexplained factors. So everything that we included in the model, all of those social determinants of health don't fully explain why we're seeing differences here. And so basically what we concluded in this analysis is that clinical factors, including upstream disparities in these that drive some of these clinical factor differences, do not fully explain the observed differences in major lower limb amputation rates, which indicates disparities do exist against what some people were arguing. We also further found that hospital factors and social determinants of health do not fully explain disparities in rural and non-rural Black, Hispanic, and Native American patients, which to us suggests that implicit bias is having an impact on clinical decision making for these marginalized patients, and it's leading to poorer outcomes in them. There were some disparities in this analysis. So one of the big ones is we only had inpatient data. So we're likely underestimating comorbidities because we had to look at prior inpatient care and if they didn't have any, so they were fully managed in an outpatient setting, then we wouldn't have been able to fully capture those. Some treatment for PAD is provided in an outpatient setting, and so we knew we were underestimating things like revascularization rates as well. We were also only able to include two individual level social determinants of health or proxies for those, so sex and insurance status. And so some of unmeasured social determinants of health likely contribute to the unexplained disparity. One of the things we spend some time thinking about in the paper is language barriers, particularly for rural Hispanic patients, where we saw instead of 10 or 15% of the disparity being unexplained. I believe in rural Hispanic patients, it was like 30 to 40%. And so we believe language barriers is likely one of the big unmeasured factors in addition to implicit bias. Now, on a broader kind of level, thinking about this analysis, this is a novel approach using machine learning and observed to expected ratios to allow us to better, in my opinion, better assess whether disparities are present and, start to dig into how much are explained by allowable and unallowable measured factors. This allows us to better get at whether or not disparities truly exist, and if so, what the burden of disparities play in the specific outcome. Importantly, it also allows us to move beyond comparing outcomes between populations. So again, allows us to not have to use non-Hispanic white as the reference, right? Because we're estimating the expected number of events in a population and then comparing it to what we actually observe. So the patient population you're interested in, rural Black adults, urban Hispanic adults, rural white adults, they serve as their own reference in a way, which I think has a lot of strengths. Um, Additionally, because you stratify after running these models, it's pretty easy to assess intersectionality across a host of factors. You just have to have a sufficient, cell counts as you stratify, but there's nothing to stop you from assessing across 3, 4, 5, 6 different characteristics. It also allowed us to indirectly study, implicit bias in this sense, but can also allow us to study unmeasured or hard to measure causes of disparities by trying to look at this, unmeasured portion. And while machine learning sounds scary, it's actually pretty easy to implement and interpret these results because at the end of the day, it's just a fancy chi-square test. It's just an observed to expected ratio. So some of the future directions that I'm thinking about and would be happy to talk about more, I decided to leave a lot of time for questions. But I have extra slides if you guys want to dig into the methods more. But I'm thinking about trying to apply these to different patient populations and look at non-surgical outcomes. So the nice thing about amputation is it's a single event, it's a single time point where things like complex treatment plans, so whether someone receives guideline concordant cancer care or adherence to preventative care guidelines where you have to undergo screening for cancer, for example, breast cancer every 2 years, can this kind of approach be adapted to look at these kind of more complex outcomes instead of this like single time point outcome? We're also looking into applying this to EHR data, which I think would be a better fit for this because then instead of just including a yes or no diagnosis of diabetes, we can actually include labs and other clinical measurements to better try to capture clinical and biological allowable factors in order to better be able to capture that allowable portion to better estimate how much disparities exist. We're also, as I mentioned, using more robust machine learning approaches, so semi-structured, unstructured, working with a biostatistician to try to, apply some of these approaches. And then something we're thinking about now, which I don't have an answer for, but if anyone does, would love to hear it, is, right now we have these three models, right? The empty model, the allowable model, and then the allowable plus unallowable model. But is it possible to assess how much different domains, so, within the disparity, can these models tell us what the biggest driver of disparity is? Is it specifically distance to a clinic, or is it, access to transportation or insurance, or, what is the primary driver? So, can we build models that, provide kind of factor loading values for these different domains? And then, but things we have to think about is how do we determine what order we build them in? Because that can play a role. But anyway, that's something that we're thinking about trying to incorporate so that way we can get even more information out of not just what proportion is due to just, what proportion of disparities are due to social determinants of health or measured ones, but which ones are the biggest drivers. So then we can then kind of engage in future directions as far as what can be targeted for interventions and care to improve health outcomes in these populations. And with that, I'll take some questions. Like I mentioned, I do have extra slides, but I prefer conversation than lecturing, so I figure I will leave it here for now.
Please join me in virtually, thanking Dr. Strassle for this very insightful talk today. Thanks, Dr. Strassle.
Yeah, thank you for having me, and feel free to reach out if you have any questions or want to chat further. I included my email at the end.